So China faces significant tumor burden of thyroid cancer, with the annual new case account more than half of the global annual new case. And also there is a 5-year survival rate less than 93%, which is suboptimal compared with the United States, which is more than 98%. So all these figures suggest there is a relatively high proportion of the late stage or advanced stage thyroid cancer patients, which underscore the importance and the urgent need of comprehensive thyroid cancer management. And over the recent years, a lot of guideline and consensus have been put forward by different societies. And also, all these guidelines, I think they played an important role in the standardization for managing the advanced thyroid cancer in China. However, there are still some challenges in China, like uneven medical resources and also less cooperative among the multidisciplinary team, especially in some remote area. So all this urged most of the Chinese professionals in thyroid disease, which should working hard for that.
In the United States, I think that the overall trend is very different than in China, because what we have seen in our population in the last 15, 20 years is an overdiagnosis of early stage thyroid cancers, leading to overtreatment of thyroid cancers that generally have a very good prognosis. And what we've realized is that many patients are found to have thyroid nodules when they're having testing for another reason. So incidental thyroid nodule detection has become quite common. So if a patient has neck pain and has an MRI of the neck, a thyroid nodule might be found when it never would have been found had the MRI not been done. So there has been an overdetection, over-testing, and over-treatment of small thyroid cancers. Now we are aware of that, and so here in the US, the trend has been to cut back on a very aggressive initial workup, to be more judicious about the workup of incidentally found thyroid nodules. So we try not to do a fine needle aspiration of a thyroid nodule if it's less than 1 centimeter in size, and simply follow that so that we don't detect a thyroid cancer in somebody who might be older, who will never develop illness related to their thyroid cancer. And then those patients are not overtreated and subject to the risk of treatment. And so in a sense, one of the major trends has been to do less in terms of approaching thyroid cancer rather than to continue to do more and more and more. We also see that in the treatment approaches to thyroid cancers. Many thyroid cancers that have a very good prognosis and are very small might now be treated initially by surgery with a hemithyroidectomy rather than a total thyroidectomy, so that patients don't have more surgery than they need to have. We're also seeing that with the applications of radioactive iodine. If patients have a very good prognostic, differentiated thyroid cancer, then not all of those patients will currently receive radioactive iodine, whereas 10 years ago, those patients pretty much all received radioactive iodine.
In China, it is nuclear medicine physicians who are responsible for the disease, for the decision making for radioactive iodine therapy. And it is also the nuclear medicine physician we can identify the radioiodine refractory thyroid cancers. That would be the most part of the advanced thyroid cancer in China. So we will identify that rare DTC patient and also taking care of all those patients during follow-up. And whenever there is a progression disease, then we should organize a multidisciplinary team to discuss such case. And for those with locally recurrence, surgery is the mainstay. And for those with maybe diffuse metastatic patients, then systemic therapy like tyrosine kinase inhibitor is indicated for such patients.
Yeah, I agree with that. And I think that's very consistent with the approach to advanced thyroid cancer in the United States. Certainly at large academic medical centers, patients are almost always treated in a multidisciplinary setting. Here in the US, in smaller communities, creating a multidisciplinary program can be difficult for patients where there isn't such a large concentration of experts in any one field. And then we have the same approach to advanced disease in patients with differentiated thyroid cancer that's iodine refractory. When they recur, if they have recurrence limited to the neck, if surgery can be done, that's always prioritized over systemic therapy. You can eradicate the disease in some cases. And then when patients do have metastatic disease that's iodine refractory, then we begin to think about treatment either with TKIs or tyrosine kinase inhibitors or with gene-specific therapy when there is a kinase fusion that's driving the cancer, like a RET kinase fusion, an NTRK fusion, or even an ALK fusion.
Nowadays in China, especially after sorafenib finally got approved by the National Medical Product Association, NMPA, in 2017, and lomatitinib finally got approved in 2020. Followed by that, the NMPA has approved many domestic Chinese products like donafinib, anlatinib, as well as some selective like RET inhibitors. So nowadays in China, our patients have many treatment options. But meanwhile, we can see there is diverse approach for the selection of the first-line treatment, and quite different from the United States, where cabozantinib is established second-line treatment modalities. In China, cabozantinib is not available. So this kind of unavailability for cabozantinib left the second-line treatment selection less standardized and also very personalized in our clinical practice. And also, many different Chinese academic societies, we have actively draft and put forward many treatment guidelines, as well as some guidelines and consensus specific on RET alterated patients and also anaplastic patients and medullary thyroid cancer patients. All these guidelines put forward many recommendations in detail. And I think this greatly promotes the standardization of the management on advanced thyroid cancer patients. But I think overall, both China and the United States will all emphasize on the multidisciplinary team cooperation for advanced thyroid cancer patients. And also we emphasize evidence-based and personalized approach. But the difference in drug availability and also some regulatory rules, which led some different approach in our clinical practice. Also, the lack of the second-line treatment, established second-line treatment, left our second line treatment much more diverse and personalized.
In the US, we will be hopefully seeing the publication of the updated new American Thyroid Association guidelines this year in 2025. And those will be for DTC. There are updated guidelines coming soon for medullary thyroid cancer, or MTC, as well. So for the DTC guidelines, I think related to advanced thyroid cancer, what we are seeing now in our patient population and physicians taking care of patients with advanced thyroid cancer is that molecular testing for patients with iodine refractory disease who need systemic therapy is now really emphasized because there is an important subset of patients who have druggable alterations, particularly RET fusions and TRK fusions and ALK fusions. We have RET-specific, TRK-specific, and ALK-specific therapies that are highly effective and very well tolerated for that subset of patients. So in general, those inhibitors are available to use in the first-line setting for that subset of patients whose cancers harbor those alterations. So that's one thing that I think will be different in the new guidelines. We have lenvatinib and sorafenib available and approved by the US FDA for patients with progressive iodine refractory differentiated thyroid cancer. And so if one of the kinase fusions is not present in the cancer, then those certainly are the first-line therapies of choice. Particularly lenvatinib now is used more commonly than sorafenib. I think what we'll be seeing in the upcoming guidelines is that there's, not only is there a personalized approach in terms of molecularly targeting specific therapies, but we're also coming to realize that there are some patients who will have iodine refractory disease that's low volume, asymptomatic, and growing slowly. And there will be other patients that have a large volume of disease or might be symptomatic or have disease that's rapidly progressive. And those two patient populations are not all the same. And so the latter patient population generally needs to start effective therapy now. But we're trying to personalize the initiation of therapy for patients that have low volume, slow growing disease. And we often will carry out a period of disease monitoring, keeping the TSH suppressed, but not initiating a TKI right away, because the TKIs don't cure the disease. They can work very well for a long period of time, but they don't work forever. So for some patients, it might make sense to delay the initiation of a TKI therapy for some time. And so we try to personalize the initiation of TKI therapy as well with our patients. And now we're talking about shared decision making, where the physician and the patient together make a decision about when the right time is to initiate a TKI therapy if they don't have that more aggressive variant of disease. I should say also, as Dr. Lin mentioned, the second line options for cabozantinib, which of course is available in the United States. I look forward to the completion of a clinical trial looking at dabrafenib and trametinib in the second line setting for BRAF V600E mutated disease that Dr. Lin was a lead investigator on, and I was able to participate here on the US side as well. But those data are not yet available.
Thank you for the suggestion. We will struggle for that. But currently, it is not that easy because we need a collaboration about that. And I should say, there are a lot of things remain open to answer, like the dose in China, the dosimetry, and also, like Lori said, the right candidate and the timing. So there are a lot of work we need to do in the real world.
So I think that we expect that in the upcoming ATA guidelines for DTC, we will be seeing an emphasis on molecular diagnosis for all patients with recurrent and metastatic iodine refractory differentiated thyroid cancer. I think that we will anticipate that if patients don't have archival tumor tissue available for molecular diagnostics, that whenever possible, a fine needle aspiration or core biopsy can be done prior to the initiation of therapy so that we can select the best treatment option for patients when they have iodine refractory progressive disease. Application right now of liquid biopsies for patients with advanced thyroid cancer, or in other words, the circulating tumor DNA blood assays, because at present the assays that we have are unfortunately just not sensitive enough for patients with thyroid cancer.
We should say thanks to the American colleagues because we are the followers of American guideline since its first edition in 1996, and then followed by 2009 and 2015, and we expected so long comes the final 2024 draft. We were all impressed by the evidence-based sense from our American colleagues. And also, we can see their serious attitude towards each clinical questions they raise. Also, the evidence interpretation and also the very prudent recommendation they finally recommended. I think all this influenced a lot on us, including me, myself, and a lot of Chinese doctors, as well as worldwide doctors in our managing advanced thyroid cancer. They greatly reshape our philosophy for managing this kind of patients. And I'm happy to see that in terms of the management of rare, that means RAI refractory thyroid cancer patients, the new draft 2024 reflects strong alignment with the perspective of Chinese experts, which we have drafted and published our radioactive iodine refractory thyroid cancer guideline in 2024, last June. So we can see we share the same opinion on simplify the definition of radioactive iodine, initially do not uptake the radioiodine, or despite the initial uptake the radioactive iodine, but finally progressed. This too simplified definition, I think it's enough to describe the radioiodine refractory status. And also, both guidelines emphasize on the molecular profile to guide the personalized or more personalized therapy for such patients. And also, we are so honored to see that evidence from China have been adopted by the new ATA guideline. Some performance from the domestic Chinese pharmaceuticals like donafenib, apatinib, and anlotinib have been introduced in the new guideline. And we're happy that this means our work have been well acknowledged by our international colleagues. So I think that is our point. And also, we're looking forward the new edition get published in July. Okay. As Laurie mentioned before, that evidence from SELECT study as well as the Chinese domestic multi-center clinical trial named Trial 308, as well as some post-hoc analysis from Lumatinib. I think Lumatinib have demonstrated great impact on patient outcome in terms of prolonged progression-free survival or even prolonged overall survival in patients aged over 65. So all this solidified its as a evidence solidified its to be recommended as a priority in most of the guidelines in China. And also we can see it was recommended as a standard of care for rare DTC patients. And I think despite all this advantage, we should pay more attention on that. We should put more attention on the further exploration on the timing for initiation and also for the dose exploration and also maybe for some combination and balance the efficacy and the risk as well.
So regarding SELECT, the top line results I think were really quite striking. The progression-free survival benefit was highly significant. There's a high objective response rate. So I think that the SELECT trial showed that lenvatinib really is a highly effective therapy for patients with iodine refractory differentiated thyroid cancer. I think that one of the key takeaways from the SELECT trial is that adverse event management really is very important. One thing I would say is that the cumulative effects of lenvatinib adverse events can add up for individual patients over time. And so managing the patient's symptoms while maintaining patients on treatment, I think is key so that each patient really can derive the longest benefit from treatment as possible. If patients are optimally managed on treatment, we can help them stay on treatment and then they can derive the effectiveness of the therapy for many months, if not years. So hypertension is the most common adverse event that was seen in the clinical trial. You have to make sure that a patient's blood pressure is normal before they start lenvatinib, but you also have to monitor the blood pressure after starting the drug because hypertension is so common. Then when hypertension is encountered, you don't want to just stop the drug. Instead, you want to manage the hypertension optimally so that you can maintain patients on therapy. The same is true for diarrhea, for nausea, for hand-foot syndrome. For most patients, these adverse events are quite manageable. Some patients do need to have dose holds and dose reductions, and those are tools that are available to us. But good supportive care is also really critical for patients that are on these multi-targeted kinase inhibitors. One other thing that I would say about the right starting dose is that we know in the Western population from study 211 that the initial recommended phase 2 starting dose is the right phase 2 starting dose for the Western population. And I think that those data can't necessarily be applied to other patient populations, but I think that we've got good data from study 211 that in the Western patient population, we really should be using the higher dose for most patients, but then doing dose holds and dose reductions when necessary in clinic.
I do agree with Lori about that. And one comment is, despite a lot of selective inhibitors, like RET inhibitors developed and got approved, but in China, I think multi-kinase inhibitor is the mainstay for rare DTC patients because a high price prevent some of our RET alteration patients from its clinical use, as well as most of the patients they do not cover any genetic mutation. So the multi-kinase inhibitor like lumatinib is our first choice in the real world. I think this would be a trend because even though tyrosine kinase inhibitors' performance in progressive radioactive iodine refractory thyroid cancer is great, but it will be eventually got resistance or failure. So combination with other like immunotherapy like that is the trend. I can see tyrosine kinase inhibitor like lumatinib. It can suppress the VEGFR signaling pathway and slow down the tumor growth, and then improve the microenvironment of the tumor, as well as enable the immunotherapy more efficacy. So I also learned that the combination use for anaplastic thyroid cancer, as well as some poorly differentiated thyroid cancer, it performs better with amazing objective response rate in ATC is over 50%, and also in poorly differentiated DTC is over 70%. That is amazing. It really changed the managing status for such patient. And also in China, we value such combination as the second line treatment options. I think in the future, we will do something further to explore to find the real candidate, and also to identify the biomarker for such combinations efficacy prediction.
Yeah, I agree completely. The preclinical rationale for the combination of a VEGFR multi-kinase inhibitor and an immune checkpoint inhibitor is really very good. And that combination has garnered healthcare authority approvals in several different tumor settings, although not yet in thyroid cancer. There was a relatively small ITOG, or International Thyroid Oncology study, that we did looking at the combination of lenvatinib and pembrolizumab for RAI refractory differentiated thyroid cancer in the first line setting. It was a small study, and we didn't see such a strong signal that there were subsequent more definitive clinical trials done, unfortunately. One signal that we did see was in patients who had progressed on the multi-kinase inhibitor and then had the immune checkpoint inhibitor added, we saw an objective response rate of 15%, which is really fairly encouraging. I think larger studies are needed, though, to show that that is a bona fide approach in that patient population. And I agree that the combination of an MKI and an immune checkpoint inhibitor in anaplastic thyroid cancer and poorly differentiated thyroid cancer also looks really promising. Again, the clinical trial data that we have is from relatively small studies and small reports at this point. We really need to convince our colleagues and our government and industry to fund a definitive clinical trial of that kind of combination in patients with anaplastic thyroid cancer, yes, poorly differentiated thyroid cancer, and also in the second line setting for DTC. So we have our work cut out for us.
Yeah, I do agree with the point from Professor Laurie. I think there is a saying that there is no boundary on thyroid care between countries. Let's work together for the health of our patients in China and in the United States.